as Claire mentioned, my background is professional sport. I've been in sport for about 12 years, and originally started in rugby and Australian rules football, so I had a lot of experience with contact-based injuries. So tape was just something I used a lot of, but more traditionally the zinc oxide tape, so the rigid tape. And around that time, the Jenny McConnell techniques were really popular for patellofemoral pain. So it was something that, I guess, as physios, potentially osteopaths as well, you had a lot of exposure to. Kinesiology tape then exploded in 2012, around 2012 in the UK, but at the Beijing Olympics, there was a guy called Keso. He was a Japanese chiropractor, and he was trying to get, he wanted to figure out a way of trying to maintain fascial improvements that he'd seen in treatment, between treatment sessions, so trying to, I guess, long out the benefits of the treatments he was delivering. So he developed kinesiology tape. As a marketing genius, he gave every travelling physio and therapist who went to the Beijing Olympics free tape and free courses at the Olympic Village. So suddenly you had these athletes from around the world on TVs around the world wearing this brightly coloured tape. So it started a little bit of an explosion, and I think, like anything we get from a therapy point of view, you know, you get phases where it's really overutilised. You know, you get a new skill, you want to use it a lot. I remember being obsessed with Dr. Magnus, thinking it was the greatest thing ever because I'd seen a lecture from James Moore and Dr. Magnus, and then after about 6 months you realise it has no relevance to your practice whatsoever. But I think what we found now with kinesiology tape and with zinc oxide is probably an area where it actually works really, really well for our patients, but in specific circumstances. We're going to speak about that obviously as we go through the course. Has anyone any experience with kinesiology tape before? Yeah? So like a lot of people, I just started YouTube and stuff, just got my experience from that and playing around with it with patients, and you know, developed from there. So it's one of those things, it's obviously very practical, and we're going to spend the majority of today doing practical. We've got about 5 minutes of just a little bit of discussion first. The way it differs from zinc oxide is that it's made predominantly of cotton, so 96% cotton and 4% nylon. It's the nylon that gives it its stretch. But because it's cotton-based, it's actually really comfortable for patients to wear. So if you've ever used the traditional zinc oxide on patients, it's really good for structural support. It's really good for trying to improve, I guess, postural control, and it's good for, as it's kind of designed, to give structural stability from one point to another. Whereas the kinesiology tape is designed to move with your body, so it's a lot more comfortable for patients to wear. But because of its stretch, it doesn't offer you the same components that zinc oxide will. We'll talk about that a little bit as well. So it stretches anything up to 160% of its length. We'll play around with that obviously when we get going on the practical side of things. I think what also helps with our patients is it's generally waterproof and sweatproof, so you can put it on. It's better to the skin than zinc oxide, so I think you can leave it on comfortably for some patients, anything up to 5 days, depending on the patient, the skin condition, and what you tell them about wearing the tape as well. But you'll always have those patients who will come back 10 days later and they just love it being on, so it's disgusting and it's hanging off, but they still thought they were getting a benefit from it. But I would say anything up to 5 days. After that, I generally just say, from a skin hygiene point of view, take the tape off and just give the skin a little chance to heal. And like we would say to our patients with anything, you know, if you start to react, it's itchy or red around the edges, just pop it off in the shower. But you can always use a little test strip on patients beforehand, and if they have a reaction. I always say to my patients, do you react to a sticky plaster? So if they've ever reacted to a sticky plaster, then they're more than likely going to react to that. Zinc oxides, some zinc oxides have latex in the adhesive. Our kinesiology tape doesn't. I can't say that for all brands, but some people have very strong reactions to latex. So it's just something to be aware of when you are putting it on your patient. How does it work? So if you look at any of the original literature from Keso, he I guess, and what they still teach now, and every company is ever so slightly different, is the way he described it is that your fascia is designed to sit on top of each other in layers, and when you put the tape on, the tape lifts the subcutaneous skin, that offloads the first myofascial layer, that lifts, and then the layers underneath glide a lot easier, and that's why you get benefits with movement, but also because you lift the layers, you offload the sensory receptors, so you get a reduction in pain sensation. Like anything, you kind of believe what you're taught, and then you start questioning it a little bit. I guess anybody who's seen this dissection of fascia just doesn't align itself in really nice uniform layers. It's hundreds of millions of interconnections between tissues. So that I always struggled a little bit with that. And the kind of patient I always go back to is that really acute anterior knee. So it's like a Jill Cook's tendinopathy continuum. That really reactive patellar tendon. That is 7 out of 10 with a single leg squat. And they squat 7 out of 10 VAS, functions poor, reporting pain. You put the tape on, you get improvements in movement, but the VAS pain drops to 3 out of 10. If you scan that tendon pre and post taping, you've done nothing to the pathophysiology of that tendon itself. You've changed absolutely nothing about the mechanics of the tendon in the sense of how it physically presents. But you've improved their movement and you've reduced their pain. So the only real way you can do that in such a short space of time, from my perspective, is sensory input. So the way we teach it is, we apply the tape, and because you do that, you increase the afferent stimulation. So you get nociceptive afferent stimulation because you put the tape somewhere locally. So your sensory receptors in that area now are picking up the sensation of tape that is attached to the skin. And because of that, you inhibit the nociceptive signals going to the spinal cord in kind of the same way as the pain gate theory. If you're reporting something else, then you're not reporting pain. So by virtue of that, then you'll generally get a reduction in pain. But because you've got some local stimulation, you'll have better afferent input to that area, so more than likely the improvement in movement comes from just better awareness of where that limb is and the position of that limb, and the response that you get from the higher brain sensors. So I guess where that differs from Keso Kazi is that we're not really saying we're having a physical impact in the sense of lifting and moving and helping fascia to play. What we're really doing is getting a neuromuscular stimulation, which improves pain and improves movement. And I guess what you'll find is lots of companies will teach it in very different ways. Whether you take what we teach or you find a reasoning somewhere else, like anything we do, it's important to understand why we think it works so that we can explain it to our patients. And also we can clinically reason why we use it ourselves. Any glaring disagreements with what I've just said? Does that in some way make sense? It's kind of like anything we do, so you find a clinical reason for why it works and you want to be able to explain that. Evidence-wise, there actually is a randomized controlled trial that said that tape and exercise was better than just exercise alone in shoulder impingement. There's been some stuff around ACLs. It's not really a sexy topic, so it doesn't get a lot of research. And actually, any of the research, when you see that it's been sponsored by a taping company, I always get really suspicious of the results. So there's not a huge amount of evidence out there about why it actually works. But again, we use it with our patients to report benefit. We use it as a tool within our management of rehab. And like I said, it doesn't replace anything that we do. So why do we use it to aid muscle ligaments, tendons, and motor control and attempt to prevent further injury? So I guess what we tend not to do is use it, so I don't say to my patients or my athletes, I'm going to put this on and you're going to run faster. That just is not true. So it's an adjunct around rehab and in prevention of further injury, or getting somebody back to a specific activity, or you get your chronic backs and self-employed people who come into the clinic and they need to go to work the next day. So we're trying to facilitate that as much as we can. It's not all about, obviously, athletes, and I'll say athletes a lot just because that's who I work with, but this is obviously applicable to everybody you see on a day-to-day basis. To enhance proprioception, like we talked about, that sensory stimulus, we're improving the awareness of that limb by virtue of giving some local sensory input. To reduce stress on injured structures, we use it to offload, and to enhance athletes or individuals' confidence in return to activity. So if that's sport, then it's sport, but if it's not, if it's just being able to get up in the morning, go to work, then obviously that's why we see a lot of the people that we see. When do we not use it? If the injury is really unstable and there's signs of serious trauma, no amount of tape is going to fix that. So they obviously need extraction and some further management. If the injury has not been fully assessed and diagnosed. If the area is extremely irritable and swollen, signs of skin infection, obviously you're not going to tape over that. You're going to make that worse, more irritable, and potentially spread infection. Over uncovered broken skin, so marathon season, January, February, March, people are starting to push their mileage. That's when they start to get their little niggles and they come in and see you. Got blisters on their heels because they're pushing their mileage a little bit. Just cover the blister with a pad and then tape over. Just don't obviously tape straight onto broken skin. If the sensation is poor and there's if there's signs of circulation changes. Not so much with kinesiology tape, but with rigid tape. I worked in Australia for 2 years, and so an anchor, it's when we use a strip of zinc oxide as a base to stick on more zinc to. I didn't explain that very well. But if you close an anchor around the limb in Australia, you've already negated your professional insurance. So there has been cases where people have used zinc oxide and applied it with too much tension, and it has caused issues post-application. You won't get it with this unless you are really putting it on tight, and if you are, then you're definitely doing it wrong. Because it stretches in the nylon properly, like I said, it makes it more comfortable, so the danger of that is pretty minimal.
Sorry, going back. You void your insurance if you do a full...
Yeah, if you close an anchor, yeah. So if you tape somebody for an ankle inversion injury, they go okay, so you've closed an anchor, so you've wrapped one strip of tape around fully and closed it without a gap in the tape, and something happens to them, then you're insured because you've applied it that way.
What's the rationale then?
Just they've obviously had cases where people have put it on too tight and they've had claims and they've had to pay blood or neural tissue. There is a famous case in America. It's not necessarily related to tape, but I always tell the story on courses just to scare people. It was a US under-17 female soccer player. She broke her fibula in training, went to the orthopaedic, his plaster nurse was gone home, so he plastered it on a Friday evening, went away for the weekend. She, on Saturday, just felt her foot a bit numb, but she'd never broken her leg before, so patients don't know what they don't know, so she just thought that was normal. By Sunday, just didn't really feel a lot, and by Monday the tissue had already started to necrose. He put the head of the plaster on so tight that it killed the fibular nerve, and she'd have to have a below-knee amputation. So that's a really extreme case, and you're obviously never going to apply tape to that extent, but you can have an impact. It's like when we tape it, we always say just check capillary refill. You know, you squeeze the nail bed, if it returns within a couple of seconds, then the circulation is fine. Two-touch discrimination, can you feel 2 fingers over 1 finger? It's really simple just to do a quick check. But like I said, with kinesiology tape, because of the nylon, you're really going to have that issue. It's more the reactive element. Patients can sometimes come up with a nasty rash just based on their skin allergies or maybe a property of the tape that doesn't. Like I said, no allergy to anything, particularly latex. But like I said, our brand doesn't have latex, but we can't say that about everything. And it's never a substitute for our assessment and our diagnosis. So I think we're all, especially in sport, I think you're always going to be in danger of just being in that situation and I've been there before. Oh, can you just quickly minute my neck? It's like, what? She's like, oh yeah, I just need you to like quickly minute my neck. It's like, no, I need to do an assessment first. Even if it's a 60-second assessment to be able to justify why you're doing something. In the same way, we apply tape because it's one part of our management strategy. It doesn't replace anything that we do. And there is some really outlandish stuff out there about what tape can do, according to some companies. And that's absolutely fine, we're free to teach that, but you know, common sense, it's just one adjunct, like you will use soft tissue, like you will use manipulation, like you will use needling, like you will use mulligans. It's just another adjunct to have in a toolkit. And it has a really good place in that toolkit, but it certainly won't change people's lives. It's just a really good adjunct to have. Like, so again, you know, we'll run through all the basic principles and then we'll start putting them together, conscious that, you know, 2 hours will go quickly and there's a lot to cover. So we'll just get cracking and we'll start applying the tape to each other and just get a feel for what it's like. There's 3 basic principles and I'll teach you those 3 principles. And then it's just applying it to the clinical picture in front of you. So we're, and certainly on our courses, we do a 1 day, we don't teach you how to apply the exact same technique to every muscle in the body. you all have clinical experience, you've all been in the profession, you understand that we tailor what we do with our patients based on the assessment and the picture that they present with. In the same way we use those taping principles. What do I need to achieve with this patient? How can I adapt that tape to support that? So that like I said, it's not massively prescriptive. And then, what do we say to our patients? Just make sure that you've got something that they can understand. I just say to my patients, when I put the tape on your skin, there's sensory fibres in your skin that pick that tape up. And because they're now picking up the sensation of the tape being on the skin, they're not really reporting pain, so your pain will drop a little bit. But also because now you're more aware of that tape being on that area, you get better feedback to that area, so the muscles will move a little bit better, and you'll generally move better as well. So patients can relate to that. It's something simple. If they're into sport, there's always somebody from the sport point of view who has worn tape. Gareth Bale used to wear it, so that was my opening line. You see the pink tape Gareth Bale wears? Yeah, they're buying. So it's just something obviously to have that your patients can understand. There's 3 different types of cuts that we're going to go through. This is called a lymphatic cut. This is called a white cut, so it has a base and then 2 tails. And then this is called an eye cut, so it's just one straight strip. But again, we'll run through all that in the practical element. Really, your life is sad when the quality of the scissors makes you really happy. So good scissors do make a difference. Crap scissors will fray the edges. The edges fray, it catches on clothes, comes off a bit easier. We round the edges so that it stays for a lot longer. And we'll again go through that practice. Make sure the skin is clean and dry. Doesn't like oil, doesn't like hair. My physio bag always had a beard trimmer in it. Always consent if you're going to start shaving people's legs or wherever is hairy. And actually, I always get permission for that one. And actually, sometimes when the stubble is at just skin level, the tape nearly adheres a little bit better actually. But if you're going to get somebody to wet shave, it needs to be 24 hours afterwards before you tape. So if you've got somebody coming in and it's a recurrent injury that you're going to manage over a period of time, and they're maybe still training or they're still active, and you get them to wet shave the area, just make sure there's 24 hours to let the skin settle before you put the tape on, or else they're going to shave. The neutral technique is where we stretch the muscle and not the tape. And we do that because, again, if we're talking about that, I guess the neuromuscular element of it is that when we stretch muscle, we get a lot more activation within the muscle itself because of Golgi tendons and Ruffini fibres and Pizzini fibres and all of those sensory fibres that pick up length and tension within the muscle. So then we don't really need to stretch the tape because we're getting as much sensory input from stretching the muscle as we need. With the stretch technique, we stretch the tape because when we use the stretch technique, we're using it on tissue that is not voluntarily contractible. So we're using it on ligament, we're using it on articular surfaces. We're not specifically trying to impact a muscle or muscle group. But again, that'll make a lot more sense as we run through it. And then the lymphatic, as the name would suggest, you're using it to support lymph and edema management as opposed to a voluntary contractible muscle or another tissue such as ligaments. So first one we're going to do is sacrospinal, so lumbar spine, and this is an eye strip. Can I use some of these lumbar spine? Has anybody got a stiff lumbar spine that they think is lumbar? Yeah, everybody. Well, you'll all get a chance to practice on each other. Can I grab one? Okay.
Which one?
Just a top, please. Perfect. And then just as you are, hands on the front leg straight and then slide down as far as you can. So where are we there? Distal shin, yeah. Perfect. So if you, I'll just show people if you can jump this with me. So we want to pick up as much of erector spina in the lumbar spine as we can with this application. You can use a wide cut, which would be the tails with the base in the middle and a tail going on each side of erector. Because it's such a big muscle group, I tend to use 2 eye strips. So again, put your strips, and then to round the edges, just fold it over. And then it just, like I said, it has better longevity if you fold the strips. So like I said, with this technique, we want to stretch erector as much as we can. So get our patient into flexion. And for me. and then over into side flexion so that we're winding up erector on that side as much as we can. Take the base off. Try and touch that as little as possible, because the more you touch the adhesive, the less sticky it's going to be. And then you just lay it down. Just make sure it's stuck. And then again, same on the other side, so down and then stretch. I'm always conscious of patients with acute back pain in this position. So, you know, if it's disky and you just don't want them going into flexion, then you need to think of another position. I like getting them into 4-point kneeling because they can kind of control that position themselves and sit back on their heels as much as they feel comfortable. And they're a lot more supported in that position and they feel a lot more comfortable with it. So you'll see, because you've stretched the tissue and you put the tape on with no stretch, when you do come back to normal, you get some nice puckering along the tape. And then if you turn around for me, and then just straight out the front. See, maybe a little bit. Picked the wrong spine there. So I would use that in acute tissue, acute facet, acute disc. If I can be sometimes quite aggressive with my needling. So if I've got somebody I've needled their QL or I've needled their erector a lot, and I know they're going to be uncomfortable afterwards, this is a really nice way of trying to minimise that after treatment and to just make them feel a little bit better about the fact that they've paid you to beat them up. So it's a good way of just giving some feedback afterwards and making them feel a little bit more comfortable with the treatment that you've done. Yeah, let's try that one in your group. So it's, like I said, 2 ice strips, stretch the tissue, not the tape. Measure the flexion first and then measure it afterwards to see what the change is. Okay? Etc. You're talking about thinking about it more from the neurophysiology as opposed to the structural physiology of the tissue. That's our philosophy. So when you're thinking about it on those terms, it's not necessarily about the structural properties of the tissue itself, it's how that tissue is innervated. And that's what we're trying to influence. We're going to move on to a deltoid now. Has anybody got an impingement or anything that's a bit active? Yeah, let's have a look. Do you mind popping off the t-shirt? Is that okay? Yeah. How long has it been going on for?
Forever.
Ever had anything done with it or just pain through range?
Sorry?
Any pain through range?
Yeah.
That painful arc, that classic.
Yeah.
So hands in front and go straight up over the head. How 10?
There it's okay actually, it's more...
When you come up here,
yeah.
just relax a minute. Any pain there?
Yeah.
Yeah, how 10?
4 or 5.
Okay, nice and strong for me. Just keep it there and then push back against me. Any pain?
Okay actually.
There?
Okay, usually that would hurt.
Yeah.
Okay. It's typical, isn't
it? Turn and face me, fingers to thumb to the ceiling, arms nice and strong, don't want to push it down. Anything there?
No.
Thumb to the floor, nice and strong. Anything there?
No.
Okay, so just in.
Yeah.
So just when we're compressing it. So right, so we're going to use a white strip. Again, depending on the muscle bulk, if you've got a big burly rugby player and you want to pick up as much of that deltoid as you possibly can, you would just use 2 ice strips with the same base. But with somebody who is a little bit smaller, you don't necessarily need that amount of tape. So I'm going to measure just below the deltoid tuberosity to above the subacromial arch. And to cut my white strip, you just fold it over and then you've got your white strip. Okay. This one's really nice. You can just take the base off, pop the base just underneath that deltoid tuberosity. And we want to stretch the tissue, so stretch the deltoid within the confines of the patient's presentation. So if there's pain, we want to make sure that we're not pushing them through that. But if I want to stretch the posterior fibers of the deltoid, I'm going to come up into elevation, horizontal adduction and internal rotation as much as the patient can. And then using the back strip, just follow the line of the deltoid and you're going to finish just around the subacromial arch. This works really nicely for shoulder impingements, anything kind of acute rotator cuff. I've used it as a part of an application for offloading the AC joint if you've got a little bit of an acute AC joint as well. And then to stretch the anterior fibers of the deltoid, you're going to come into a extension as much as possible, and then a little bit of external rotation, so you're stretching those anterior fibres. Again, if that's an acute shoulder, is that uncomfortable?
No, it feels nice, good stretch.
And again, just following the line. And because the tissue is on stretch, we're not stretching the tape. And then down. And then just make sure you take it. So, hands in front, straight up over the head. Hands
Yeah, good.
Don't expect this to change massively, it's more about the movement.
Yeah, that's fine.
The reality is, if I was working on this shoulder, obviously I'd assess it fully first, but this alone is probably not all I would use. I would maybe do, in this case, you've got some anterior shift and a bit of an internal rotation on that. I'd probably want to try and retract that shoulder a little bit and externally rotate it, open that bicipital groove, try and decompress the subacromial arch first. So you might use this as a foundation of your application and then add little bits to that depending on what this shoulder really needed. That's just a nice way of demonstrating how to do a Y strip on a shoulder. So let's try that one as well, yeah. Let's go and do that. So same principle, tissue stretches, tape doesn't, but it's a Y strip and it's on a shoulder. That's a hamstring or a gastroc or whatever the muscle is. The muscle stretches, the tape doesn't apply the tape on with no tension with the muscle and stretch. So you can all clinically reason that to anywhere in the body. We're going to move on to another of the basic principles, which is the stretch technique, and we used it in a couple of different circumstances. Can I was going to say grab a leg, but that makes me sound a bit weird. Can I use your leg for a second? So this is a stretch technique, and like the name suggests, we use it because the tape stretches and not the tissue. And generally we use this technique because it's non-contractile tissue, so it's not voluntarily contractile, so it's basically, it's not muscle. It's ligaments, it's hematoma, it's articular surfaces. So just seat up for me and pop your legs up as well.
Straight out?
Yeah, so just the one sitting. So works really nicely for acute hematomas. This is just the first one that I'll show you. So you get somebody with a dead leg, dead quad, whatever. They've just taken a heavy impact or a fall and got some really nice edema and a hematoma coming up. And if the center point of that hematoma is here, this is the one where you're going to tear the tape with two bases and then take out the middle portion. So you're left with two really nice tabs that you can hold, and then you're going to stretch the tape. And we say between 50 and 75% stretch. So it's not like, I think that's 68. It's literally, that's 100, take it back a little bit. So as long as you're stretching it. Center point of the hematoma, 50 to 75% stretch, lay it down over it, and then just take the bases off. So there's no tension on the bases because the stretch is in the center portion of the tape. And you're going to build that up. So this is one of those, again, we're trying to have a sensory input, 50 to 75% stretch and over, but it's one where with the stretch in the center, it is trying to recoil. So what you're trying to do is lift the tissue over that hematoma to improve the circulation. So you can do it like this. And you really, this just depends on the size of the hematoma and how much tape you want to use. How much you like your patient, yeah. Or who's paying for the tape.
Do you charge extra for your neck?
I just never saw that really sits poorly with me. I just what I will do to patients if I know they're going to use it a lot, I'll get them to buy a roll for themselves and I'll teach them how to tape themselves, or I'll teach somebody that they know how to tape it for them. So we do that with our patients a lot. That's one that works really nicely for hematomas. The next one example of how we would use this, and the question came up a little bit earlier around using this for more structural stability, and I think that's where this has its real limitations by virtue of the fact it's made of nylon, in the sense that it's partly made of nylon, it stretches, so it doesn't give you an end feel. So if you're using it for structural stability, it's more about somebody's awareness that they need to correct a movement pattern or a position, as opposed to this is going to do it for them And we talked a little bit about that in groups around the posture correction. And we use zinc oxide traditionally because it just gives you an end feel, because that's what it's designed to do. It doesn't stretch, so you know exactly where the limb should be. This is more of a feel and a sensation, and it's a little bit more subtle. So
will you use the two together? Kind of thing?
absolutely.
Yeah.
What, we run a course which is combined, and we use both. I actually, probably nine times out of 10, my applications are combined. I think they work absolutely brilliantly together. Because what one doesn't give you, the other does, and vice versa. And actually the discomfort you get sometimes with zinc, combining it with some kinesiology tape makes it really comfortable. And it makes the zinc last so much longer, because if you cover it with this, it's waterproof and it'll stay on better. The issue with the zinc is it has a really good place in what we do, but it just doesn't last long enough, and it's not comfortable, and it's not waterproof. So the longevity is really, really poor. So if you just spin over here for me and just perch on the end.
Yep.
So if this was an acute MCL, so MCL injury, or this is applied to any collateral ligament in the body. So I've used this miniature ones for fingers. And you want to give them, this is more about a little bit of feedback. So this is, if I was rehabbing somebody after a skiing injury, or they're a sports person, or they're just wanting to get back to normal life, and they're at nearly the end of that rehab process. So I'm pretty confident they're stable. They may have a tiny bit of laxity, but actually I'm starting to load them a little bit. Or they want to get back to their sport, and I want to give them just a little bit of protection on that. But not to the same extent that I would need if it was acute and there was a lot of play there. So I don't need zinc oxide, but I want to give them just a little bit of support. So MCL, where it crosses the medial joint line. Again, center portion of the tape out. 50 to 75% tension, and just cross over that joint line. And you're going to double up. You can do 2, 3, again, depending on the size of the limb and the level of feedback you want to give. So that's given me a little bit of feedback around the medial aspect of my knee. If I'm playing football and I've got a little bit of an instability there, and somebody tackles me or I turn with force, that's not going to stop me from maybe potentially injuring that again, or I guess preventing that level of valgus that's going to cause some pain or discomfort. It's good at a certain point within that rehab process. But if you've got somebody who's a little bit more unstable, then I would be using zinc oxide. And this is one of the times I would absolutely use zinc and this together. What I would do is put those two straps on. I would go over this with zinc oxide, and then I would go over it again with kinesio. So you've got 3 layers. So you've obviously lost a little bit of the structural stability from the zinc oxide because you've put kinesio underneath it. But it actually still gives a little bit of structural tension in between. So you've sandwiched it in between this. It stays better and it's waterproof, so it'll last a game or even last through work and showers.
Would you put the same way?
Yeah.
Exactly.
So
the same
literally
way.
just, and then with the zinc, just go straight over that, and then another two straps of kinesio over that again to waterproof it and keep it nice. And
would you anchor that with a kinesio around here?
I don't. If I'm going to use just kinesio as the base, then I don't think you need an anchor. If obviously you're putting the zinc directly to the skin, then I would always anchor. But if you are, so say they needed more stability than a combination would give you, and zinc is your primary application, then absolutely, like you said, anchor, tape, re-anchor, and then I might cover it off with this. So then I'm getting more structural stability because the zinc is directly to the skin, but it'll stay better and it'll be waterproof because I've covered it in kinesiology tape. So again, that's exactly what we've been talking about, is what is the patient presenting with? How much stability do they need? That's what we do with all of our interventions. We gauge it based on what our patients need. So it's the same with these. Once you know the principles, it's just about applying it to the patient from the... anterior knee, and it's probably the one that is the most adaptable. And part of that is because there's so many different things that can be wrong with a knee. And again, a lot of these applications are overlapping in how we would use them depending on the presentation. So we'll apply it and then we'll talk about how, because there's been some really good questions about PFJ and patellar tendonitis and all of those issues. And actually very often some of the same applications just work really nicely for all of them. Are you happy to use the so give us just a little bit of history.
Both kneecaps dislocate regularly.
Laterally.
Medially.
Medially. Oh.
But MCL's both dodgy. Right ACL's ruptured, right MCL's ruptured. Cartilage tears, leg cyst.
Anyone else got
We want a cure out of this.
Yeah, I'm going to be playing hockey next week.
I think I just have to take a phone call. Any pain with squat? No pain with squat.
No.
Single leg squat on that right side?
On the right
Or
side.
with
That's fine, yeah, that's as much ankle as
any
anything.
pain with that? Or
Not in the knee at the moment.
okay. Left side single leg squat?
That's all it's just done.
That's not too bad. Any pain with that single leg squat?
Not really.
Okay, well, we'll just use it as an application. So, again, anterior knee pain, PFJ, patellar tendinitis, trying to correct the patellar shift. Foundation is very, very similar. Can you just have a light up on your back for me, please? So, we want to try and influence the patella, obviously, but we're also trying to actively, I guess, positively influence the quads as well. So, one eye strip, and you're measuring from just below the hip flexor, so you're picking up as much of that quad bulk as you can, and then you want to finish just below the patella itself. What I'm going to do is then just fold over the patellar portion and cut that into a Y. So what you end up then is quite a long eye strip, and then the little base of the tail or the length of the patella. So you want that split to be just above the patella. Okay? So I'm going to tear from there. So it's one I will start down this end because then I know exactly where I'm going to finish. Pop that down, get a little bit of a stretch on that quad as much as the patient can tolerate, and then stick there. I'll just go over there. And then with the tails, there's going to be a little bit of stretch on this. And you're going to come down medial and lateral. So you're finishing tibial tuberosity. And then down. Next strip is a Y strip on top. So this is, like I said, a general application for an anterior knee issue. If when I assessed I thought there was a lateral shift or a medial shift, at this point here I'm probably thinking about correcting that. So the way we talk about order of efficacy a lot with treatments, and the way I describe it with taping techniques, if you're using 2 or 3 different techniques within one application, then you just go by order of priority. So if I think in this instance correcting the patella is the primary aim of the application, then I will correct the patella first, and then I'll go stage back off that. So if then I want to activate the quads a little bit, then that will be the second application, etc. So you always start with the priority application. It's what I wanted to say, but it took a lot of words to say that. It's only Monday.
Can I ask these
Question.
about if they were quite strongly kind of want to laterally?
So there was a lateral shift. Yeah, and again that comes back to the property of the tape. So you're not going to get a massive correction with this because of the nylon. The tissue is stronger than the tape, so that it'll move. Again, like we talked about earlier, what I would more than likely do with that is if there was a lateral shift, I'm going to just deviate a little bit quick. Then I would want to correct medially. I'll come to the lateral border, I'll correct the patella, I'll put my tape down, but then I'll go over that with zinc oxide, and then I'll go over it again with kinesiology. I find when you go directly on the skin with zinc oxide for PFJ correction, they squat into a chair and it just pops off. It just doesn't stay on. It works really well, but it doesn't stay on. And I think if you layer it, then it stays on really well. You lose some of that structural correction because you put kinesio underneath, but actually what you've lost with that, you've gained by the fact that it will just stay on. So at least it's
And
giving
would
you
they
some
be
kind of-
exactly the same size, or would one be
just a little shorter because you want
a little?
the kinesiology to cover the zinc. You can go zinc onto the skin and then kinesiology over it as well. If you just depends on comfort. It's a lot more comfortable, particularly I find when you do zinc oxide applications to patella, it's quite uncomfortable. Patients can report quite a burning sensation. So if that's what I was going to do at that point, then I would do that. In the same way, if I thought that was a rotation, I might try and correct that rotation. If I thought there was some insertional discomfort from the ITB and that lateral patella, I might do an ITB application on that as well. So get a little bit of a stretch through there, ITB application. So again, you're just tailoring to whatever the patient needs. The second part of this application then is another Y strip, starting inferior pole this time. In flexion, we know that the patella has come out of that patellar groove, so it's a little bit more control on that point. And again, this might not be how you tailor it, but this is just a really good anterior knee application. And then down. So what you've got then is medial and lateral support to that. So if you were saying to me, I'm dislocating medially, then I might add a lateral correction to try and block that medial dislocation, or I might put a strip here as nearly like a barrier to that. It just depends, or just like I said, whatever you think the patient is presenting with. And then the last bit of that application, which sometimes is just something you might use on its own if they've got a little bit of inferior polar bursitis, or they're just a bit grumbly around that inferior pole of the patella, maybe they're just a little bit reactive in that patellar tendon. You know, you see that again, the Jill Cook reactive tendon, they've just gone and run and haven't run for a long time, or they've done a day of doing something in the garden where they've just overloaded that patellar tendon. It's a little bit acutely uncomfortable. There's no change in the physiology of the tendon itself, it's just uncomfortable. This can work really nicely as well. So this is like we did with the stretch technique, center portion out, and like you do with the zinc oxide, the Jenny McConnell stuff, you want to catch at least an inch of that lower patella, lift, and then lay the tape down. And again, you might just use that alone if it's just to offload the inferior pole of the patella and there's maybe not another issue there. That's a really good adaptable knee application that works for tons of stuff. And just for grumbly knees, it just works really nicely. Pop down and see what it's like, and it's really comfortable. So again, around marathon time when people are pushing their mileage a lot, they're coming in with grumbly anterior knees, this is just a really nice one to pop on. It's really comfortable, isn't it? Yeah. And you feel supported. So you really can add anything to that. If they have, you know, like we see stereotypically with a lot of those people who get medial knee pain, they just roll when they plant, they get valgus through the knee, we say they've got weak glutes, but they're just not controlling that plant. You can get a tape on the inside of the knee around and up onto the glute, and you're just trying to sling that from dropping in immediately. And that would work really nicely with that application as well. So again, it's just whatever that patient is presenting with, think about, and then you can apply the tape in whatever way they need. Let's try that one. That one's a bit more fiddly, and we've got a couple more in run through. And then we've got some special. We'll do a lymphatic as well at the end. I want to show you the lymphatic technique. Let's do Achilles, because Achilles is something like grab your Achilles and just jump up at the right time. Pop down on your front with your feet over the edge. Perfect. So Achilles tendinopathy, really nice technique to use. So again, measure from just below the heel to a couple of inches below the knee crease. And you want to have an eye strip over the tendinous portion, and then when it gets to the muscle tendon unit, when it gets proximal to that, you want to have it as a Y strip. So kind of similar to what we did with the knee, where you have an eye and a Y basically attached together. I always say on courses I'll knock it around the edges, but then my OCD won't let me knock. So you're going to break it in sections. So you're going to have a base section,
then you're going to have a section for the tendinous part, and then you're going to have a section that goes over the MTU, and then you're going to have a section for gastroc. So you're going to put the base down, and just take your time, try and get it so that there's no creases, because if there is and they go running, you're going to give them a blister and they're not going to be happy. I'm going to put that foot in some dorsiflexion, then I'm going to go 75% tension on the tape over the actual tendon part, then 50% tension over the MTU, and then like we do with our traditional principle is no stretching the tape for the gastroc component. So when we're actually on the muscle itself and not on tendon. And if there is, you know, with some of those chronic Achilles, what you tend to get is a little nodule on the Achilles themselves, or if that's a really acute reactive Achilles tendon, you will have a portion of acute tenderness on the Achilles itself. So you get a small ice strip with that stretch technique, 50 to 75% tension, and over that tender area, pop it down. Yeah? It works really, really nicely for even posterior ankle impingements, Achilles pain, any Achilles bursitis. It's a really nice offload for the Achilles tendon, particularly again in those runners who are just getting a little bit grumbly through that Achilles and gastro. Okay. I'll show you the lymphatic. Can I use your ankle? Can you just pop her over onto your and then just slide down a little bit. So,
you were going to be using pink tape.
do you want me to change? I worked in football. I worked for Arsenal for 2 years, and we had a kid who was on so much money it was disgusting, but lovely kid. He'd been looked after by one of the other physios, and I came in one day and the physio was off, so I had to tape him, and I was putting some pink tape on him. His face was like, is there something wrong here? I was like, this is the leg I'm supposed to tape. And he's like, yeah. I was like, right. I was like, what's the issue? He goes, oh, Colin always uses the blue tape. I was like, and the issue is? And he goes, oh, I thought like the blue tape cooled me down and the pink tape warms up the muscle. Just get out. Yeah. So yeah, people have some weird. Worryingly, I'm sure he was probably told that at some point, as opposed to he didn't have the brains to come up with that himself. He was a lovely kid.
Or was it Arsenal youth you were there?
And no, first team.
Oh, right.
So, yeah, Arsenal.
Because you said kid, so I was just...
Oh, well, he was just one of the younger guys. Yeah. They were all younger than me. Yeah. So, lymphatic technique. I tend to just leave it at 4. If you try and get any more tails than that in, it just becomes too difficult to cut. And again, like I kind of did that while I was talking. A really easy way of doing that is just folding it over, leaving a little bit of a base. So, people who have issues with lymphatic drainage, upper limb, lower limb, what you're going to do is use the base as close to the nearest lymph nodes as possible. So if I'm doing an acute ankle, so this is an acute ankle sprain, I've got some edema pitting laterally. The closest lymph nodes are the popliteal lymph nodes at the back of the knee. If that was an acute knee, then I have femoral or inguinal lymph nodes. If that's an acute upper limb, then I'm going to head towards the axillary lymph nodes. We used to say it's contraindicated if you're doing an upper limb, or if the nodes that you want to draw the fluid to have been removed. So mastectomies that have had node removal, you don't want to bring fluid to an area that can then be removed from there. So I used to say that was a contraindication, and then I actually had a physio who worked in cancer care on the course, and she said, well, you just do a technique to the opposite axilla. And yeah, absolutely. I'm not sure how effective that would be. I kind of err on the side of not. If I know that lymph nodes have been removed, I'm not drawing fluid to another area that can be pitted. Also, if you think there's an active systemic infection that could be spread by moving lymph, then you're not going to tape. So we've got these two. This is where you can
weave them.
Yeah, this is where you bring out your artistic side. So an acute ankle, ATFL, tear, partial, strain. I'm going to put the base again as close to that popliteal lymph nodes as I can, and then 15% tension. And you weave it so that you're covering more surface area. And it also looks cool. I was seeing a guy in private practice and he'd had an acute ankle. And just by virtue of the fact that I ran out of tape, so I had one was blue and one was pink. He loved it. About 6 months later, I just came across his Instagram somehow, and he was still wearing it in the gym. I was like, "There's nothing wrong with your ankle," and he was like, "Yeah, but it looks really nice." It's like, wow, it's a different level.
So this doesn't matter how you look.
No, it's just you're trying to cover. You ultimately you want to go over the area that's edematous so that you're drawing as much of that up as you possibly can. And then I would go medial with the next one.
I heard of a story where somebody kept the tape on for so long that skin started to grow over it.
Wow.
Wow. I don't know how. I think it was like a third handicap, so I don't know. But
It's one of those, yeah, urban myth. Although some patients you have, I would wholly believe that. So post-operatively, those really swollen knees after a knee replacement, or acute ACL injury, any sort of an injury where you've got edema around the knee, works really nicely. And in the same way you would do that, you would inguinal or femoral, and then you would do the fan over the knee. So you're taking the fluid up towards the femoral or inguinal lymph nodes. If that's the upper limb, from humerus to axilla, so I put a base anterior, posterior from the axilla. I wouldn't put the tape in their armpit. I'm not going to thank you for that. And bring that fan down. If it's wrist and you're trying to do the whole limb, then I tend to break it up into segments, because if you try and get it too long, it just, when the elbow bends and flexes, it starts to roll and it'll come off. So I'll do one section that'll bring it to the elbow and another section that'll bring it up to the shoulder. Yeah. Works really, really nicely with, remember that hematoma lift that we did with the star? If you've got a really nice hematoma somewhere, you put the star over the hematoma and then you do the lymphatic drainage to the star. It works really, really nicely of getting rid of some of that hematoma.